Okay, we've been listening this morning so far to what's going on at the national scene, and now we're going to talk about what's happening here in the state of California. And for those of you who are actually listening to me, thank you very much. This is always the hardest part because I know we all love to talk to each other, so there will be a great opportunity at lunch, and there's plenty more time at the reception this evening. So I'm going to introduce, I want to make sure I'm saying it right, Hannah Katch. I originally said Hannah. She said, no, that's wrong. It's Hannah, so now I have it correct. She is the Assistant Deputy Director for Healthcare Delivery Systems at the California Department of Healthcare Services. And in that capacity, she oversees the divisions that operate the operations, quality and monitoring of managed care plans, the long-term care programs, and the systems of care program for vulnerable populations. So she clearly knows a lot about the work that we do. And she's had a very interesting kind of history in the various work that she's done, and I want to share some of that with you. She spent 4 years as Senator Franken Senior Health Policy Advisor and primary health care staffer on the Senate Health, Education, Labor, and Pensions Committee, also known as the HELP Committee. She then took the leadership role in developing several key pieces of legislation that were passed into law, including the Drug Quality and Security Act of 2013, the Violence Against Women Act of 2013, and the Food and Drug Administration Safety and Innovations Act of 2012. She also worked closely with congressional leadership, the U.S. Department of Health and Human Services, and the White House on implementation of Affordable Care Act. So she's got a great history that she brings to the state of California, and I see why they snatched you up. So I'm going to turn this over to Hannah Katch, who's going to share with us what's kind of the big picture of what's going on at the state level. And then right after that, we're going to hear from the panel on mental health and substance abuse services from the department. So, Hannah, it's all yours.
Thank you so much. I really appreciate the opportunity to be here today, not just because I get to spend a short time in the beautiful San Diego weather, but also to talk about one of my favorite subjects. And so thank you for that warm introduction. I did, and actually in the Senate, a couple of pieces that I wanted to mention. Much of my work in the Senate focused, yes, sorry, in the back. Oh, volume up? Okay, sorry about that, I'll speak up. Much of my work in the Senate actually did also focus on mental health issues. The senator that I worked for, both senators that I worked for actually cared very much about mental health issues. Senator Kennedy is the first one, and Senator Franken. And so I actually was able to play a significant role in the 2008 Mental Health Parity and Addiction Equity Act, as well as the Mental Health Awareness and Improvement Act, which just passed the Senate Help Committee for the second time yesterday, which is very exciting. So I am here in my new capacity. I still call myself new, even though I guess I've been there for 10 months as of today, is to talk about our 1115 waiver. Does anyone know what an 1115 waiver is? Okay. I feel like I delve into like the Medicaid waiver wonk speak very quickly, so I hope you will stop me if I start to do that because I recognize that most people don't live there. So for those of you who do not raise your hands, an 1115 waiver is essentially the state's global agreement with the federal government about how we're going to run our Medicaid program. So for anything that we want to do in Medicaid that isn't already required or provided by statute, an 1115 waiver essentially allows us to negotiate to do more than what the Medicaid statute is telling us to do. And so much of the innovation, much of the exciting work that we want to do and to partner with you is in our 1115 waiver. And I'm sure that if you haven't already, you will hear about the substance use component of that from my colleagues from DHCS. I'm going to talk about the portion of the waiver that is not related to substance use. So the Bridge to Reform waiver was approved in 2010, and that waiver was California's biggest waiver by far. I believe it was actually the biggest waiver ever in any state. And that waiver was really focused on the opportunities provided by the Affordable Care Act, and it was about expanding access for a huge part of the population and to bring the Medicaid expansion population, the newly eligible Medicaid population into our program and make sure that they had access to the services that they needed. So I will tell a little bit about sort of the success of the Bridge to Reform waiver, but in addition to that, what we have been sort of from a big picture focusing on over the last year is to try to think about, okay, we did this huge thing. We brought millions of people into our program, many of whom had never had access to healthcare before. There were some bumps in the road, as you may have heard about, but we did it, and we're continuing to do it. And so where do we want to go from here? What do we want our program to look like in 5 years when this waiver is over? To do that, we spent a little bit of time thinking about where we've been. So the Bridge to Reform waiver cut the uninsured rate in California by 50%. We also had the nation's first DSRIP, which is essentially delivery system reform pool. It's an incentive mechanism to create delivery system reform in different areas of our health system. And we completed the full implementation of a managed care delivery system, as well as promoting the long-term and effective use of state and federal funds. So this is the coverage. This is my favorite coverage chart. So it's the red is the uninsured rate and the blue is the Medi-Cal enrollment. So we take a lot of pride in this. And then this is managed care enrollment. So as you all likely know, we moved very heavily towards a managed care delivery system for Medicaid. And that, I think, has a lot of benefits, and it also has created some challenges. And so in moving forward, a lot of what we want to do over the next 5 years is figure out how to better align our systems around our beneficiaries and make sure that our systems are really working for the beneficiary. So this is our overall vision, and the Medi-Cal 2020, that's where we want our beneficiary to be with everything else around them. And the core goals of our new waiver, our 2015 waiver, which we're calling Medi-Cal 2020, improve health outcomes, strengthen primary care delivery and access, build a foundation for integrated healthcare delivery system, and that also significantly means finding ways to integrate our behavioral health and physical health systems, as I'll talk about more, addressing social determinants of health, and also using our system as an incubator to test innovative new ways of delivering care. So those are our very easy, achievable, small goals. So I want to stop actually for a minute and make a disclaimer, which is that we asked for a lot of stuff in this waiver, and I think as anyone knows who's been in a negotiation, we aimed very high. And we are not, don't tell CMS I said this, but we're not going to get everything we asked for. This was really our way to build a roadmap to where we want to be in 2020. We asked for between $15 and $20 billion over 5 years. We got 10 last time. That was our first strategy. Our second strategy is really where the meat of the policy is, and that's where I'm going to talk a little bit more about. And then the third strategy is around transforming the public safety net and changing the way that we provide care, particularly to the remaining uninsured. So that core strategy 2, where a lot of the policy is, that is, for me at least, really the interesting stuff. So these are our 6 strategies within that big core strategy. I'm going to focus on the ones that I think will have the most effect on your work, but I'm happy to talk about any of them if that's helpful. So managed care transformation and alignment, that core strategy 2, is really around how do we align our systems better, given our primarily managed care delivery system in Medi-Cal, how do we better align our systems and provide more of a seamless experience for our beneficiaries? And then core strategy 5, I think also has a really significant impact on anyone who works with individuals with mental health and substance use disorders, because we have been really focusing on how we better serve individuals experiencing homelessness, many of whom, disproportionate numbers of whom, have a mental health or substance use disorder. And then the 6th component is what we are calling the whole person care pilots, which is a really exciting concept around providing both flexibility and support for counties that want to better integrate care in a number of ways. So managed care transformation and alignment. So we have we had several focus groups. We had 5 focus groups, working groups, where we asked a number of experts from across the state to come together and just talk to us about what problems they see, where we can go from here, how we can do a better job of serving our beneficiaries. And plan provider incentives, or managed care transformation and alignment, as we renamed it, was a really important conversation, I think, between our managed care plans, beneficiaries, providers of all kinds. There were county representatives there. It was a great, really robust conversation about some of the challenges that our beneficiaries currently have getting care, as well as providers and plans have in providing that care, and how we can do a better job of serving them. So we came up with a few strategies that we've proposed. The first one is around shared savings with our managed care plans. And I'm telling you about this one because I think it creates an important incentive for our managed care plans to try out new and different ways of collaborating and serving all of our beneficiaries better. And so I am gonna delve a little bit into Medicaid nerdland for a minute, so bear with me. Currently, the way that our rate setting and our capitation works for our managed care plans is that they get paid a capitated rate, as you know, per beneficiary per month. And then they are required to cover all of the health services that beneficiary needs, and they get to keep the extra. And so that should provide an incentive for them to keep the beneficiary healthy so that they don't have to access the service, as many services. We all know that. The problem is that every 2 years, we look at what they spent and what their costs were, and we rebase. So we take away the extra. And that takes away the incentive, essentially, to keep the beneficiaries healthy. Because if they spend less on services, then we'll just take away that extra. And so what we're proposing to do is essentially to define narrow areas of the rate setting where plans want to really try innovative new programs. And if they are effective in both reducing costs and improving the health outcomes of their beneficiaries, then we'll split the savings with them. And so it's a way of incentivizing that sort of innovative and collaborative work that we really want the plans to do, and that many of them really want to do and can't make a financial case for now. The second strategy is around pay for performance for provider organizations, and this includes mental health plans, as I'll describe. So this is really a strategy to try to create a standardized P4P core set of goals across the state. So right now, a lot of plans will pay providers or at least a part of their payment to providers will include some sort of pay for performance. So based on achieving certain metrics, they can get either an performance bonus, or they can earn back some of their payment. But between plans, it's not standardized. And so what we heard really clearly from providers is that many providers, most of our providers, participate in more than one plans network. And so it's really hard to participate in several different P4P programs. They're all measured differently. And so what we're proposing to do here is standardize across the state the P4P programs with some flexibility. So plans can still choose to provide P4P for additional things, but there should be one core set, and the providers should know exactly how it's going to be measured. And that includes behavioral and physical health integration. So the next component, there is a specific, which I'll get to in a minute, P4P for behavioral health. The third strategy in managed care is broken into two parts. The second part is the P4P. The first part is actually at the plan level. How do we help the managed care plans and the county mental health plans collaborate better? And so this is really about creating a formal agreement to share incentive payments between the plans for achievement of certain joint performance metrics. We didn't define what those metrics are. We would want to have many more conversations with the managed care plans and the county mental health plans before defining those metrics. But in order to try to create more collaboration between the plans, we want to create metrics that link them to incentive payments that can only be achieved if they're working together, and when they're achieved have to be shared. So that's the goal here. And then the second part of strategy 3 is about that standardized pay for performance for behavioral health providers, and specifically would go to providers that are demonstrating integration in different ways, and particularly different tiers of integration. Again, we didn't define what this means. This was a very sort of high-level, broad proposal. This is the concept that we heard a lot of support for, but we would need many more conversations as we go to better define what this would really look like and make sure that it makes sense for those involved. So I'm going to jump to housing, and I promise I will leave lots of time for questions at the end that I may or may not answer. Fortunately, our DHCS behavioral health team is right here, so I can punt to them if I need to. But I think that access to housing is a really important component and one that I really enjoyed working on. We had, in this group, we had a fantastic group of plan representatives, providers of all kinds, housing developers, the Housing Finance Agency. And at the beginning of the conversation, they were really talking past each other. They were not speaking the same language. And by the end of the conversations, they really had learned some of each other's languages and were realizing that a lot of the challenges that they face were very similar. So we have a few incentives and strategies around trying to improve our access to stable, affordable housing for our beneficiaries who are either at risk of or experiencing homelessness. So the first one is really around allowing our managed care plans to provide a set of case management services that are specifically tailored to housing and access to housing. And so things like helping someone either at risk of or experiencing homelessness fill out a rental application, which many of them had never done before, helping them find a deposit, helping them get their utilities turned on, just really basic things that most of us don't think about that are actually huge barriers to accessing housing if you've never had to do it before. So that's the first strategy. The second strategy is allowing the managed care plans in a county to contribute to a housing pool. And so allowing them to actually pay directly for a pool of funds that would go towards room and board, direct subsidies for room and board in a county. This has never been done using Medicaid dollars, but the argument that we're making is that it's essentially an upfront investment in reduced costs and improved health outcomes over the long term. We think we'll save a lot of money just by giving people who need housing access to it. And then the third piece is a housing-focused whole person care pilot, which I'm going to talk a little bit more about in a minute. So that regional integrated whole person care pilots was a concept that came out of a lot of the county level conversations where what we heard was essentially, we at the county level are already achieving your goals. We're just doing it in a slightly different way than you've envisioned in this waiver. So don't make us undo the work that we're already doing to serve particularly our high-risk populations. Let us keep doing it and provide us the support we need to do it. And so we thought that made sense. And so we are including a proposal to essentially accept applications for county-wide housing pilots where the managed care plans, public hospitals, mental health plans, other county services, advocates, community resources, they all are in partnership to better integrate their services and better support particularly our highest risk beneficiaries. So we don't have a clear definition of what this would look like. There's actually a lot of work going on here in San Diego on exactly this that we would love to be able to do a better job of supporting. But it's essentially flexibility to do the good work that's already happening at the local level. So this is kind of what I said. So that is all I have, but I would love to hear from you whether you think this makes sense or answer any questions.
Good morning.
Hi.
Not really set up for the short people in the room. Is there a timeline on the housing projects that you were just talking about?
Yeah, great question. So we submitted our application for the whole waiver in March 27th, and our current waiver expires the end of next month, so October 31st. We hope to have a waiver by then. That is the goal. So we are currently in very intense negotiations with the Centers for Medicare and Medicaid Services. If all goes well, we should be able to announce a final waiver by the end of October. And then the different programs, I mean, we can't, of course, flip a switch and turn on all of these different programs. So we would have to negotiate a timeline about when things would start, but sometime after the end of October. Hi.
Hello, my name is Kellen Rustinello. I'm with the ACLU of San Diego and Imperial Counties.
Great.
So my question was, it seems like from the emails that I've gotten from DHCS through the negotiations that the shared savings portion does not look like it's going to get approved by CMS. Does that apply to the housing provision? And if so, what does that mean for the supportive housing proposal if that doesn't get approved?
So the shared savings that email was referring to, and there was an email maybe a month ago, I want to say, 6 weeks ago, that went out basically trying to give a brief update on where we were in the negotiations. Shared savings was one of the two things that was taken off the table at that point, but it wasn't talking about the shared savings that I just described. It was talking about a global shared savings mechanism for financing the whole waiver. So no, it doesn't affect any of the strategies that I just talked about. The waiver financing is incredibly complex, and it is one of our biggest challenges. And so to the extent that we can't find the financing to do a lot of the strategies that we want, that would have an effect on all of this. And to the extent that it requires new funding, which almost all of it does. So we are working very closely with them to try to figure out a next best financing mechanism. The other, just so you know, the other proposal that was taken off the table at that point was a workforce proposal that also was not part of what I just described. Yeah.
My name is Karen Leto. I'm with the California Association of Mental Health Peer-Run Organizations. And my question relates to the workforce development piece that you haven't described, and specifically how peer support specialists would be built into this type of proposal.
So the workforce strategy that we had initially outlined was about how do we provide incentives for either providers who don't currently serve Medi-Cal beneficiaries to serve them, or for those who do currently serve Medi-Cal beneficiaries to serve more of them. And then there was another component that was around trying to enhance the culturally and linguistically competent workforce currently serving Medi-Cal beneficiaries. That proposal is unfortunately no longer a part of the waiver. We did not discuss sort of how different types of programs would fit into it, but unfortunately it's not moving forward at this point.
Hi, my name is Marika Collins, Casa Pacifica. We're serving children and families in Ventura and Santa Barbara counties, and I will start by saying I do not live in the weeds on this waiver, so I apologize if my question isn't a good one. With respect to the housing piece that you just spoke of, for MHPs and agencies that are serving primarily children, but by extension their families, is there a way in which the MHPs and agencies might be accessing those housing funds if they're truly if we're really serving the children, but really it's the family? You know what I'm saying?
I do, I think. So is it fair to rephrase the question as
Please do.
If the child is on Medi-Cal and is receiving county mental health services, but the parents are not, can they still, sorry.
They're not
Can
the
they
ones
still
maybe
access?
that we're serving, but it's the child welfare system that is, and so
yeah.
therefore, but by definition, if we're not serving the family and their needs, which would primarily, a big piece of it obviously is housing, then we've missed the boat.
It's a good question. I had not contemplated that specific question. If an individual, maybe a child, I'd have to think about how that would work, is in the Medi-Cal program and is in need of the housing and supportive services, they would receive it through their managed care plan. And so the proposal essentially hinges on allowing managed care plans to refer and pay for this set of housing-related care management services. So I can't exactly think about how that would work for a child if the parents were not in the Medi-Cal program, but it's possible that it could. We can certainly think that through. If you have suggestions, would love to hear that. Hi.
Hello, my name's Tara Shepard. I'm from Modoc County Behavioral Health. And this isn't a question specific about the waiver, but given your experience both in California and at the federal level, do you have any sense of whether there is movement at the federal level to end the carve-outs for mental health and substance use?
I'm
and
just
if
going to
so,
punt
when?
that one right to Karen Baylor. All I will say about that is that there is a lot of discussion about it, but my colleagues who specialize in this area are much better equipped to answer that question. Hi.
Hi, Stacy Hiramoto, Director of REMCO, the Racial and Ethnic Mental Health Disparities Coalition, and I also am not in the weeds. But one of your early slides really did get my interest. It was one of either the broad goals or principles, and it was to address the social determinants of health. Mm-hmm. Could you elaborate on that again in the waiver? Thank you.
Sure. So this was an area that came up frequently in our conversations with stakeholders. Is for so long we've been in the business of providing just physical health services, and expanding the way that we think about health is crucial to better serving our beneficiaries. And so part of that, of course, is better integration with behavioral health services. Part of that is really thinking about the whole person. And so what non-health services do they need, and what non-health related issues are having an impact on their health? And I like to steal a line from Mitch Katz in LA about, he says that our beneficiaries come to us fully integrated, and we are the ones that create the silos, right? And so how do we not do that? How do we actually serve the whole person? So the housing component, I think, is an attempt to do that. It's trying to serve the needs of beneficiaries when those needs impact their health, but are not specifically health. The whole person care pilots are another attempt to do that, to bring together the different systems that are serving particularly our highest need beneficiaries, and make sure that if multiple systems are serving the same beneficiary, that they're doing so in a coordinated and integrated way. And if they're not serving the beneficiary, getting them access to the services they need.
Hi, Michael Listman, Alameda County Behavioral Health Care Services. When you speak about the 1115 waiver, and I don't know the details as well, one of the really critical issues that we face in California is the cost of housing. And people on SSI can't afford any kind of safe, affordable housing in many of our counties. And I don't know if the 1115 waiver addresses that, but it's become a crisis issue that absolutely affects the social determinants of health of all of our clients.
Yeah.
So that's one issue. I don't know if you can address that or not. It's a huge issue. The other is in the 1115 waiver, there had been some discussion about being able to bill for supported employment, supported housing services. Is that still in there? Because I think those are critical issues that support the recovery of our clients.
Can you talk a little more about that second point? What specifically is it that you were wondering is still in there?
Well, to be able to provide Medi-Cal support, billable services for supported employment, supported housing, it's not specifically addressing, medical necessity, medical necessity, disability challenges. But it definitely contributes to recovery and diminishes the symptoms and behaviors that people are experiencing, and that hasn't been billable previously under Medi-Cal. And I know that there was some discussion about that at some point on the 1115 waiver, and I'm not sure if it's still part of the 1115 waiver or not.
So there is not a supported employment component to the waiver application that we submitted in March. I think the closest to what you're describing is either the housing and supportive services component or the whole person care pilots, which provides flexibility to provide services like that.
And anything about the federal government or providing any kind of supported incentives for creating affordable, safe housing for folks throughout the country, but particularly in Alameda County and California counties?
Yeah, it's a good question, and one that we really wrestled with. And I think the strategies that I've outlined around housing were our best attempts to do that. And in particular, allowing plans under some circumstances to directly pay for housing. It's a fine line to walk, because at the end of the day, our mission is around providing health services. And so we're trying to stretch that to include issues that impact the health of our beneficiaries, including housing. But at the end of the day, there is a housing finance agency, and we need to make sure that the lines there are not blurred. So in terms of actually trying to reduce the cost of housing, that is not within our mission. But one of the areas that we talked about a lot in our housing working group was around how do we create and demonstrate the need for the housing for our beneficiaries, so that developers know that there is not only a clear need, but that there is a payer willing to pay over the long term for housing for our, populations that we
Right.
serve. And
I'm
so,
hoping that Ron and Chuck can also address this at the federal level.
Yep.
Thank you.
Yes, so I think I'm getting the boot here, but thank you very much. I really appreciate your time.
Excuse me, could I just follow up that housing one quickly? Is there a way? Just because CMS did issue a memo with HUD
Yeah.
talking about housing search and different things being paid with Medicaid dollars, but that it needed to be included in the plans. Are you saying you have included those in the plans for the Medicaid funding?
So the memo that I'm aware of, the informational bulletin that they released a few months ago, is basically what housing type services can be covered in which different waiver programs. What we're doing blows right past what they said we're allowed to do, which is really what 1115 waivers are intended to do. They're intended to provide additional flexibility. So those services were not specifically housing. They were more, they were closer to like the housing-based care management services that I was describing. And we do provide those in some of our current, particularly our long-term care waiver programs, but we're proposing something much bigger to serve more people.
Okay, I just wanted to clarify
Yeah, no, it's a
that
great
you were
question.
doing that.
Yeah.
Okay.
Thank you.
Thank you. That was incredibly helpful. Really appreciate the presentation.